I'm Kira Janine, and you're listening to DNA Today.
How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, they're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
DNA Today informs you on what's happening in the genetic world. You can tune in every Monday at 11:30 a.m. to WHUS.org or 91.7 FM. Or if you're into listening on your own time, you can go to DNApodcast.com. All the episodes are on there. So today we are talking about Lynch syndrome. It is a syndrome that increases one's risk to develop certain cancers. So it's not diagnostic, which makes this syndrome kind of interesting because most syndromes that we talk about, most disorders, you end up having symptoms with it. That's pretty common for a disorder. But for this one, you have an elevated risk of developing a certain list of cancers. And Lynch syndrome is also known as hereditary non-polyposis colorectal cancer, along with cancer family syndrome, lots of other names. But I'm going to be referring to it as Lynch syndrome because that's kind of the most friendly layman's term, Lynch syndrome, and it's much easier to say. So the increased cancer risk, which ones have an elevated risk of being developed in these patients? We're talking about endometrial cancer, ovarian cancer, gastric cancer, and the highest one is colorectal cancer. So Lynch syndrome is inherited in an autosomal dominant pattern. What does that mean? That means that someone's affected by Lynch syndrome has a 50% risk of passing that syndrome on to their child. And this increases if their partner has Lynch syndrome. But in most cases, people don't both have Lynch syndrome. Usually it's one person. So what is the risk level of inheriting colorectal cancer? It has up to an 85% risk to develop colorectal cancer. So most of these patients end up developing colorectal cancer or other types of cancers, but colorectal cancer is really the one that is the highest in these patients. And I said up to an 85% risk. So this number depends on which Lynch syndrome related genes have mutations, because there's quite a few, and we'll get into which ones they are and which diseases, or cancers rather, that have an increased risk of being developed depending on, which gene you have mutations in. So some of the less increased cancer risks include hepatobiliary tract, urinary tract, small bowel, which is your small intestine, pancreatic, brain and central nervous system, and the sebaceous neoplasms. And this is the most common hereditary colorectal cancer syndrome. So it's the most common hereditary colorectal syndrome. Most cancer, not just colorectal cancer, but most cancer is sporadic, which means you don't have a family history of it. You've accumulated mutations throughout your life, and eventually cancer develops from those mutations. But when we're talking about hereditary cancer, you are inheriting a gene that has a mutation that then causes the cancer and increase your risk of having cancer because you have one gene that has a mutation that is related to that cancer. So it's the most common hereditary colorectal cancer syndrome, making it so 2 to 5% of all colorectal cancers are caused by Lynch syndrome. So it doesn't sound like a big number, but that means 2 to 5 people out of 100 that have colorectal cancers, they're getting it because it's due to Lynch syndrome, and they probably don't know it. So the prevalence of Lynch syndrome, we have around 140,000 new cases diagnosed yearly. So that number isn't that big. It's not a rare disease by any means, but it's not a very big number. There's no higher prevalence in a gender, ethnicity, or culture, and it's estimated that 1 million people in the U.S. have Lynch syndrome. So you're like, wait a minute, we were talking about 140,000, now we're talking about 1 million. But that's because we only have 5%, we imagine, based on statistics, that are diagnosed. Only 5% of people with Lynch syndrome are diagnosed. So it's vastly underdiagnosed. And that's kind of one of the reasons I want to talk about Lynch syndrome today, is to increase awareness for it. So how did we find out about Lynch syndrome? What's its history? In 1913, the syndrome was first identified, and it was identified in pedigrees with a family history of colorectal, gastric, and uterine cancer. So these families had those 3 different types of cancers: colorectal, gastric, and uterine. And in this study, they did pedigrees and found that all of these cancers seem to be related into some kind of inheritance. And this was the first study to then identify the cardinal features of Lynch syndrome. So that was 1913. Now, 78 years in the future, now we're talking about 1991. A group of international researchers agreed upon the criteria to diagnose patients with Lynch syndrome, which we today refer to as the Amsterdam criteria. So the Amsterdam criteria requires 3 things: a minimum of 3 family members in at least 2 generations to have colorectal cancer. So you're having a family history of colorectal cancer, minimum of 3 family members in at least 2 generations. One of those family members that, again, is affected by colorectal cancer has to be a first-degree relative, so very close relative, to one of the others affected. So you can have a son affected and also a mother affected. That's an example of that. The third point and component of the Amsterdam criteria of 1991 is that one of the affected individuals received their diagnosis prior to the age of 50 years old. So if you receive it prior to the age of 50 years old, so you're younger than 50, it's considered that you're kind of young for getting colorectal cancer, because colorectal cancer typically takes a very long time to develop, making it one of the most preventable cancers, using colonoscopies and other things I'll get into later. So these are the 3 criterias for the Amsterdam criteria of 1991. Now, a couple years later in 1999, this was revised because we're finding out more about Lynch syndrome. So we're like, all right, we gotta fix this criteria a little bit so we can include more people, because we're leaving a lot of people out that have Lynch syndrome but don't match this criteria. So what changed? So we just talked about 3 family members with colorectal cancer. So that was something that needed to be done, right? That you had to have that family history of it to be diagnosed with Lynch syndrome. This was changed to 3 family members to have any Lynch syndrome associated cancer. It didn't have to be colorectal cancer. It could be uterine cancer. It could be endometrial cancer. Any type of cancer I've mentioned that's related to Lynch syndrome, they could have that, and that is one of the components of the Amsterdam criteria to then diagnose Lynch syndrome. The second component and last component for the Amsterdam criteria 2, which again is the revised edition, they did this in 1999, was to have a tumor to be verified by pathological examination. So what does that mean? You get a biopsy and it's being examined by a technologist to say, all right, does this look like Lynch syndrome? What do we have here? So now, between these times of, the original Amsterdam criteria and it being revised, there was a discovery of a cancer susceptibility locus. And that means that there was a gene that seemed to be correlated with getting these types of cancers. And it was found on chromosome 2 on the P arm, which means P, we can remember P for short because it's like petite. And this discovery was followed by a finding of MLH1 located on chromosome 3, also on the P arm. So finding these 2 genes and saying, hey, wait, this is associated with Lynch syndrome. We're seeing patients that have Lynch syndrome have mutations in these genes. So what causes Lynch syndrome? We have things called microsatellites, and these are di, tri, or tetranucleotide tandem repeats in DNA sequences. Let's break that down. Di, tri, tetra, 2, 3, 4. So we have 2, 3, 4 nucleotide tandem repeats, tandem next to each other, and repeats. We're repeating within the DNA sequence. So we're having this nucleotide being repeated in a DNA sequence that maybe shouldn't be repeated. And the number of repeats is variable. So some patients may have a lower number than others. This was originally, when it was discovered that Lynch syndrome patients had this, it was originally called replication error phenotype. Now we refer to it as microsatellite instability. So if you're reading older literature, you may see it being called replication error phenotype. Now we call it microsatellite instability. And so this is causing Lynch syndrome, but what is causing this feature, microsatellite instability? Microsatellite instability is caused by mutations in mismatch repair genes. And now you say, what's a mismatch repair gene? Mismatch repair genes are the cause of Lynch syndrome, and if a mismatch repair gene is normal, its function is to correct errors during DNA replication. So if we have a single base mismatch, we have an A paired with a G instead of the T it should be paired with, A mismatch repair gene, it's product, so genes make proteins. So a mismatch repair gene or mismatch repair protein would come in there and say, hey, that's not right. That's not supposed to be a G. Let's switch that to a T. So it's fixing these errors it's finding. It may also find short insertions and deletions, and we call insertions/deletions indels for short. So it's finding these things, it's fixing them, it's preventing cancer, because the more mutations we accumulate, that can then develop into cancer. The mismatch repair genes we know about, 2 of them I just mentioned, MLH1, MSH2, and the other 2 I haven't mentioned yet, MSH6 and PMS2. So the prevalence of these genes. So the mismatch repair genes, 50% of Lynch syndrome patients have mutations in the MLH1, 40% have MSH2 mutations, 7 to 10% have MSH6 mutations, 5% have PMS2 mutations, and 1% have mutations in a gene called EPCAM. Now, EPCAM is not a mismatch repair gene. Then how is it related to Lynch syndrome? How it works is the EPCAM is right next to, in our DNA, it's located, the gene is right next to a mismatch repair gene, MSH2, which I've mentioned. And that's located on chromosome 2. So on chromosome 2, we have the EPCAM gene, and further down in the DNA, we have the MSH2 gene. And there's a deletion in the EPCAM gene. And that deletion inactivates MSH2, the mismatch repair gene, from having its proteins produced, and therefore its abilities is really inactivated. So it's silencing all its activity, and it's not able to fix all those DNA errors that do happen in our body. And our body is constantly fixing those. And if the fixers are not working, it's going to remain broken. So what are the other different types of genes we are talking about? We're talking about mutations in MLH1, right? So these are increased to an increased risk of ovarian and endometrial cancer. But it's interesting because rates do not dramatically increase above population level, which is something we refer to a lot. That's like the normal level. None of us have a 0% chance of developing any kind of cancer. So they don't increase above the population level until the patient is over 40 years old. And together, the MLH1 and MSH2 genes make up 90% of pathogenic variants found in Lynch syndrome. And MSH2, so that's one that's 40%, can cause a variant of Lynch syndrome called Muritour Syndrome. And people with this have an increased risk of developing uncommon skin tumors such as sebaceous adenomas, carcinomas, and keratocathinomas. So that is, they just have more increased risk as opposed to Lynch syndrome patients that have an increased risk of the cancers I've mentioned before. We're talking about colorectal cancer, ovarian, endometrial. Those are like really the top, uterine, another one. So compared to mutations in MLH1 and MSH2, MSH6 mutations have a lower cancer risk overall. So if you're going to have a mutation in one of these genes, it's better to have MSH6 mutations than the other ones. And as I said before, these are around 7 to 10% of Lynch syndrome mutations are found in the MSH2 gene. The risk for developing endometrial cancer in individuals with mutations in MSH6 is elevated to 16-fold compared to a population risk level. So if you have mutations in MSH6, you're more looking at developing endometrial cancer rather than other types of cancer. PMS2 is one of the more rare mutations, not as rare as the EPCAM that I described. EPCAM is only seen in 1%. PMS2 is seen in about 5% of patients. And the risk of colorectal cancer is increased 5.2-fold, and the risk for endometrial cancer is even higher at 7.5-fold, both compared to the population level. So this one's really rare. It more rare than MSH2, but those levels are actually a little bit lower than MSH2. I said a little prematurely that the PMS2 gene is probably better to have mutations in actually than the MSH2. So microsatellite instability. So I mentioned what that is. How can we test for that? We have a couple different tests. Amino Histochemistry is one of them, and what that does is measures the expression level of mismatch repair genes by the proteins present. So we're not looking directly at the genes, we're looking indirectly because we're looking at the products of the genes, which are the proteins. So we're looking at the proteins. Are the proteins normal? Are the proteins not normal? That gives us a better indication if the patient has Lynch syndrome. The other one is PCR, which stands for polymerase chain reaction. And for this one, we are amplifying that gene. We can pick a segment of DNA and we put a couple reagents in there, and then we can amplify that section of DNA, and now we have a lot of it. So it's much easier to study than if we are finding that gene within the whole genome. That's a little bit daunting of a task. So both of those can identify Lynch syndrome-related mutations. We can follow up with genetic testing after these to determine which specific gene is mutated, and that's important because we're going to be able to tell different statistics based on which gene you have. So we have different levels of risk development. If you have mutations in different genes, as I just went through, some are higher for endometrial cancer, some are higher for colorectal cancer, and it gives the patients more information, and more information is always better in order to make preventative decisions and preventative measures to be able to stop cancer from happening. To diagnose this, so we were talking about figuring out microsatellite instability. Now we're looking to diagnose the syndrome as a whole. Genetic counselors are very vital in this process because it is a complex disorder. As I'm going through this, I'm going through the more basic information on it, but there's way more information that goes into this, and genetic counselors can kind of help guide patients through the process of being diagnosed, that they can help them decide which gene panels to go through, and genetic counselors know quite a bit about genetics. That's why they're genetic counselors. And they will pick the gene panel they think is the most appropriate if a patient wants to go through genetic counseling, or wants to go through with genetic testing. And there's all kinds of different tests. There are companies such as Embry Genetics, GeneDx, and Vitae. They all do these types of gene panels, and genetic counselors can really help them through this process because it is very confusing, and most people, unless they're in genetics or in a very scientific or research field, cannot understand these results without someone interpreting them for them. What are these risk reduction and screening colon cancer? So colon cancer, as I've said, is the most prevalent cancer being developed in Lynch syndrome patients. How are we preventing this from happening? Colonoscopies, as you've probably heard maybe first from Katie Couric, who actually her husband died early from colon cancer, and she went live on air and had a colonoscopy to show people that it wasn't as scary as it sounds and how preventable colon cancer is. As if you're having colonoscopies, they can catch colon cancer very early on because it's a slow cancer. So Lynch syndrome patients, instead of usually for the normal population, it is recommended patients start getting colonoscopies no matter what their family history is, starting at age 50. Lynch syndrome patients, much earlier. We're looking at 20 to 25 years old. They're starting to get these colonoscopies and then follow up every 1 to 2 years. Or they can start 10 years prior to the age of the earliest family onset. So if in your family someone got cancer, colorectal cancer at age 40, you should start getting colorectal cancers or colonoscopies at age 40. That's kind of how that works. And again, because of these colonoscopies, survival rates have greatly improved. Colorectomy is another type of... Colorectomy is a more drastic measure one can take. If tumors cannot be removed, the entire colon can be removed to prevent colon cancer from developing. If you have all these tumors and there's just too many to take out, the whole colon can be removed. This is generally not performed for Lynch syndrome patients. There is cases, however, it is way more prevalent in other hereditary colorectal cancer syndromes, such as FAP. That's one that has hundreds to thousands of polyps and tumors compared to Lynch syndrome, which has much less than that. Another risk reduction measure is using non-steroidal anti-inflammatory drugs, such as aspirins. There's been a correlation between using aspirins and reducing colorectal cancer risk levels. And also one that goes with a lot of different cancer development is just maintaining a healthy body mass index. I've read a study that they found that a certain amount of weight really increases your risk of developing colorectal cancer, even if you do not have a family history. So that was interesting to find. Just kind of, we know that kind of in the back of our head, stay on the thinner side to be healthier, but that was cool to actually read the actual facts and all of that. So for endometrial cancer, risk reduction and screening is not as successful as colorectal cancer. We have colonoscopies, which is just one of the best screening methods for any type of cancer. Endometrial cancer is not as successful. We have transvaginal ultrasounds, endometrial sampling. We can measure levels of CA125, which there's been a lot of debate whether this really does correlate that well. It certainly doesn't correlate great, but is the correlation good enough to continue using? That's highly debatable. And the use of oral contraceptives can also reduce risks of endometrial cancer. That one is if you have a family history or not. Prophylactic surgeries, you can have a hysterectomy to really just reduce your rates pretty greatly, even usually lower than population level. And there are so many support groups for people that have Lynch syndrome. One of them, I actually had a guest on my show. I have Lynch syndrome, Georgia Hearst. She runs that blog, and she also is very, very active on Twitter. She's part of the Tweet Chat HC Chat for hereditary cancer, HC Chat. And she was on episode 25, I want to say. Yep, she was on episode 25, interview with cancer hereditary experts. And she talked about having Lynch syndrome, what's that like, what that is like, the family history, how that's impacted her family. Other types of support groups include Raising Awareness, Lynch Syndrome, the Colon Club, and there's lots of others. So there's a lot of support groups out there for if you have Lynch syndrome, or if you were recently diagnosed with it, or maybe think you may have Lynch syndrome. They're really, really great support groups to go to. So there's been a lot of recent research advancement related to Lynch syndrome, and I always like to include this because this is what we're discovering new advances in genetics on this show, and these are the new advancements. All the ones I'm going to mention were found this year in 2016. So recent research has supported the hypothesis that mismatch repair deficiency, again, those were the genes I was talking about that fix mistakes in DNA. So a deficiency in those mismatch repair genes are being associated with older age. A study published in 2016 tested the mismatch repair genes, the ones I mentioned before, by performing Amino Histochemistry. That's the one that we're testing proteins, not the genes. The proteins are the products of the genes. And they were performing Amino Histochemistry on adenoma tumors found in Lynch syndrome patients. More mismatch repair genes were found in patients 60 years or older compared to patients less than 60 years of age. There's also been recent research attempts to improve current screening for Lynch syndrome. As I went through all of the Amsterdam criteria, gene panels, there's a lot involved. We want to simplify this. So one study researched a specific DNA repeat, HT17, to identify correlation with Lynch syndrome. And it was surprising to find out it's kind of a supermarker for Lynch syndrome. It's present in many cases. The study found that there's a high correlation between this DNA repeat called HT17 and mismatch repair mutations. And again, mismatch repair mutations is what's causing Lynch syndrome. So if we can find something that's picking up a lot of mismatch repair mutations, we're finding something that's picking up Lynch syndrome. With this new study, new screening methods for Lynch syndrome could be dramatically simplified, which is the goal, by only screening for HT17 instead of searching for all these mutations in the one of 5 genes known to be associated with Lynch syndrome. And not only is this easier, it would make it more affordable because it's easier, and then more people could have access to it and be tested for Lynch syndrome because it's vastly underdiagnosed. Only 5% of people with Lynch syndrome know they have it. That's the stat that we are estimating. So we need to get that number much higher. And by possibly implementing screening for HT17, that DNA repeat, we could pick up more people with it, and it would be more accessible to people. The diagnosis of the condition is important, again, as I keep saying, to decrease risk factors in developing colon cancer and endometrial cancer, among all the others I've mentioned. By finding which of the 5 current identified genes linked with Lynch syndrome has a mutation, it can give more information for the risk levels for various types of cancer that may develop. And these risk levels, once they're identified in a patient, can be lowered through increased surveillance and risk reduction surgeries. Those are the top 2 that we can really prevent cancer with. And with more advanced technologies, additional genes and variants are discovered that are associated with Lynch syndrome. An increased understanding of how Lynch syndrome works is really going to lead to better preventative measures, treatments, and even cures for the cancers that develop with Lynch syndrome patients, which wouldn't only be beneficial to Lynch syndrome patients, but would actually be more beneficial as a whole, because Lynch syndrome patients obviously are less than the number of Lynch syndrome patients are less than the number of people that get sporadic colorectal cancer. So looking at Lynch syndrome and how it works is a lot of indications on how these cancers work in sporadic cases, but sometimes it's a little bit of an increased process because these Lynch syndrome patients, instead of acquiring all the mutations needed for cancer to develop, they've already developed, they've inherited mutations that then don't need to be developed. They're already there. So they've kind of advanced in the process of developing cancer in that sense. So I threw a lot of information at you about Lynch syndrome, but there is so much more to learn. One of the best resources I like to recommend is Genetic Home Reference. That's part of the NIH, and it has so much information on it, not just for Lynch syndrome, but so many other genes, proteins, cancers, disorders, pretty much anything genetic related, which is just about everything. And what's great about this site is that it really explains things in layman's terms to an average Joe, that it's not too above your head. And sometimes it will get a little bit dense, but it's not so dense that you can't read it. Sometimes you look up a couple words here and there and you get a good gist of what they're saying. You can also go to DNApodcast.com to listen to an episode where I had, as I said before, Georgia Hearst. She came on the show. She has Lynch syndrome, and she just kind of explained the experience of having it and the advocacy work she's doing and the support group she's doing. So you can listen to that over at DNApodcast.com. It's episode number 25. There's a couple other awesome guests on that episode. That was really fun to record. So that wraps up today's episode of DNA Today. Check us out on Twitter at DNA Podcast, DNApodcast.com for all episodes. Any questions, comments can be directed to info@DNApodcast.com. Thanks for listening, and join me next week, again Monday, 11:30 a.m., to learn and discover new advances in the world of genetics.
The genes of you and me, the genes of you and me, they're all made of DNA. We're all made of the same chemical DNA.